بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم. We will start our lecture on hernia repair and surgical management of hernia. Hernias are common surgical operation is done by all general physician and general practitioner in rural areas in Sudan. And anyhow, it is a difficult operation as well as somehow it is easy. The recurrence rate is very high, even in very expert hand. So it have to be tackled very well, and the option of the operation are so many, so one have to be sure to choose the operation which he very much tackle. It is a common operation in surgical practice due to the vast number of hernias present. Concentration is going to be on inguinal hernia because it is the commonest hernia in the world. Definition: we will do our lectures in certain things. We will define the hernia. We will talk about uncommon types and rare types of hernias. We are going to define the risk factors, the causes, the etiology and epidemiology in one group, and we will be leaving this epidemiology for the student to read about it. Then the clinical assessment. This is mostly is a clinical work, how to take history of a hernia patient and how to examine the hernias, whatever type of hernia, and investigation done before the operation and preparation for the surgery. This is almost all of it is a clinical work. We are going to talk on surgical treatment, on the three types of surgical treatment: open surgical treatment, laparoscopic, and robotic assisted surgery. The problem of epidemiology of hernias. Inguinal hernias has a bimodal distribution, mostly around 5 years, and sometimes after 70 years. The patient, when he is getting old, his muscle will be weak and he is going to be prone to hernias. 70% of inguinal hernias are indirect, 90% in males, and a small percentage in females, 10%. Femoral hernia is 3% of all hernias and common in females more than males. It is 2 to 1. In every 3 patients, you find two females and 1 male of femoral hernia. In children, it is 1 to 5% and is higher in premature babies. Spagillian hernia is a rare type. It is 0.12 to 2% of all abdominal hernias. And you know what is Spagillian hernia? What's the definition of a hernia? It is an abnormal protrusion of an organ or part of an organ through the wall of the cavity or through the wall of a cavity. That cavity is abdominal cavity, thoracic cavity, pelvic cavity, or whatever it is. But the commonest place is the abdominal cavity, which is a bigger cavity in the body. It may occur at any part of the body, but most commonly in the abdominal cavity as it is the biggest one. If we talk about the anatomy, we are not going to cover all the anatomy of all hernias. We will concentrate on an anterior abdominal wall and we will concentrate on the inguinal hernia. For example, the abdominal wall is four main layers important in hernia formation. Although the abdominal wall is covered by more layers, like the most important, the four layers which are important in hernia formation. But between the skin and the peritoneal cavity, you will find other layers which are not important. The four muscles which are important: the external oblique muscle, and the internal oblique muscle, the transversus abdominis muscle, and a tough fascia called the transversalis fascia. These are the four layers. If you see the photo, you will know what are the four layers. Anatomy of the inguinal canal is more important than anything else. You have to know the anatomy of the inguinal canal before going into any operation. The inguinal canal extends between internal and external inguinal rings. The external inguinal ring is an opening, a triangular opening in the aponeurosis of the external oblique muscle. The internal ring is an opening in the transversalis fascia. It extends 1 to 1.5 inches, and the length of the inguinal canal, and it is 1 to 2 centimeters above the inguinal ligament. Boundaries and contents of the canal. The canal is having four boundaries: the anterior, the posterior, the roof, and the floor of the inguinal canal. The inguinal canals are two on both sides of the abdomen, and it is above the inguinal ligament. As I said, it extends between the internal and external inguinal rings. And for that reason, there are certain structures which form the wall, the roof, the walls, the four walls, the roof, the floor, the anterior wall, and the posterior wall. The posterior wall is mainly formed by transversalis fascia and medially by the internal oblique. The anterior wall is formed by the aponeurosis and the muscle of external oblique muscle. The floor is formed by the rolling of the inguinal ligament, and the roof is formed by the medially by the conjoint tendon, which is the internal and transversus abdominis muscle joined together, and laterally by the internal oblique only. What are the types of inguinal hernia? What are the types of hernias? Hernias, mainly there are inguinal hernias, which is of two types: the direct inguinal hernia and indirect inguinal hernia. There are hiatal hernia, this femoral hernia, which is in the groin also. It protrudes through the femoral ring. There is umbilical, epigastric, and spigelian on the lateral side, and incisional hernias. And there are internal hernias, which is like the diaphragmatic hernia, which are four in types: the hiatus hernia, the Morgagni hernia, the Bogdalic hernia, and the Morgagni hernia is anterior, and the Bogdalic hernia is posterior, mainly on the left side. There are so many types. If you see the photo, you will know what are the types of them. Mainly we are going to talk about the inguinal hernia, and mainly we will concentrate on the indirect inguinal hernia, which is coming through the inguinal canal, and the bowel may pass through the wall in an area of muscular weakness. The direct inguinal hernia is due to weakness in the posterior wall of the canal, and it is mainly medial to the inferior epigastric artery. If there is one or two words about the diaphragmatic hernia, we have types in the diaphragm. We have the hiatus hernia, which is going through the esophageal orifice, which is due to weakness of the diaphragmatic muscle and diaphragmatic ligaments. The second type is Morgagni hernia, which is diaphragmatic hernia, most probably congenital in origin. Bogdalic hernia, mainly on the left posterolateral side, common than the Morgagni one. There are other types of hernias, like the obturator hernia, which is rare in the pelvic area. Difficult to diagnose the obturator hernia. There are others, the sciatic hernia, and there is rarer bifurcation of the recti, and this is in the anterior abdominal wall. The four common types of hernias is the inguinal hernia, the incisional hernia, the femoral hernia, and umbilical hernias. I think the important thing is the anatomy of the anterior abdominal wall and anatomy of the inguinal canal that will form, because it is important in the surgery, because you are going to correct the either the posterior wall of the canal, or you are going to correct the anterior abdominal wall through which the hernia is coming. So anatomy is important. The second thing, you can touch on the epidemiology of hernias, and this is important in research history and in research and other medical conditions. We are going to touch the important thing, which is the hernia surgery. Types of repair, we have the herniotomy, which is done in children, and we have the herniorrhaphy, and this is repair of the walls, and you will not use any foreign materials. And we have the hernioplasty. This is you can use foreign body from outside, like a mesh or like sutures and so on. We have the other type, which is laparoscopic repair of hernias, and this is a technique which is new, and it is nowadays is becoming very eminent. And the new, more recent one is the robotic assisted type of repair, which the surgeon might not be in the operating theater. He might be outside the operating theater, and he will be operating on the hernia. Simple herniotomy, this is done in children. The sac is dissected, or if small enough, is returned back into the abdominal cavity. And most probably this is a congenital thing. It is found early in children. It is sometimes associated with a hydrocele. You will find some fluid in the scrotum. Treatment of the one which is combined with hydrocele is the same as simple. You have to dissect the sac and return it back to the abdominal cavity. No need for repair of the inguinal ring, because the inguinal ring most probably is normal and it doesn't need any repair. Herniorrhaphy. So many types of herniorrhaphies are done. For example, the Pacini repair, which is becoming history now, of historical origin. And this is where you are going to dissect the sac outside, and you are going to either return the sac if it is a small one, or if it is a big one, you are going to just cut the sac and dissect it and cut it. And you are going to join the conjoint tendon with the inguinal ligament. And this repair is usually under tension. And this is why the recurrence rate is very high, is up to 5%. There is because of this tension repair, there is a modified Pacini repair. Modified Pacini repair is helped by repairing the internal inguinal ring and posterior wall. There is a modern one which is Shouldice, done by the Shouldice Hospital in the United States. And this one is, you are going to repair the posterior wall in layer, maybe 3 or 4 layers, and you are going to repair them one by one. Modified Shouldice, this is where you are going to put a mesh on to help the repair by a mesh. As we said, Pacini repair, you have to mark the site before the surgery, and you have to do the incision in the external oblique from the external ring to the end of the inguinal canal. You have to expose the ring and incise the external oblique muscle with the fibers. Expose and protect the ilioinguinal nerve, because if you cut it, it's going to cause some pain. The same Pacini tension repair plus, this is the modified Pacini, the same Pacini tension repair plus reconstruction of the floor. Both of them have high rate of recurrence, the modified Pacini and the Pacini repair, and mostly they are of historical background which are eminent before. The Shouldice repair, as I said, it is used in all types of ventral hernias. It is not used in inguinal hernia only, because it is used in direct, indirect, and femoral hernia. Also other umbilical hernias, incisional hernias, Pagilian hernias, and you can use them in all types of hernias. It is a 4-layer repair with sutures, and you are going to avoid the tension repair like in Pacini. The modified Shouldice type, we said it is supported by some mesh. Hernioplasty, we have the famous one which is Liechtenstein repair, and this is usually is with a mesh. You dissect the canal, and then you support the posterior wall by a mesh, and you suture the mesh, and the tail of the mesh you divide it into two and make the cord to come out, and then you can round it around the cord and suture it there. Laparoscopic hernia repair is developed in the 1990s. Before, in 1982, Gare attempted closing the internal ring by laparoscope. But the laparoscopic hernia repair appeared in 1990, and after that, and it is developed after that. Two types were developed: the transabdominal periperitoneal repair, which is done by the newly trained doctors, and the other one, which is totally extraperitoneal repair, which is called TEP. Totally extraperitoneal. You don't go into the intra-abdominal cavity. You dissect the anterior abdominal wall, and then you don't open the peritoneum. You introduce your carbon dioxide between the peritoneum and the anterior abdominal wall, and then you work in that area, which is a small area, and during work the peritoneum may be open, and this will turn the operation into transabdominal one. You have to differentiate between the TAB and TEP repair, which is the complication of TAB is total intra-abdominal, transabdominal, what we call transabdominal periperitoneal repair, and this might injure the bowel or injure intra-abdominal structures, and adhesions might occur also in that area, and you have to excise the peritoneum and elevate it, and there are certain places in the peritoneal view, intra-abdominal peritoneal view, there are certain triangles which called the pain triangle and the doom triangle. These, both of them, you have not to dissect, because the pain triangle, there are nerves which can cause pain. The doom triangle, which is what are the external vessels are there, and it might bleed tremendously, and you might not be able to stop the bleeding. You have to know the laparoscopic appearance and the anatomical appearance of the laparoscopic view from inside, and you have to differentiate the two types of the triangles, the doom triangle and the pain triangle. You can introduce three ports, one port from the inferior umbilical area or superior umbilical area for the camera, and there are two other ports for 5 millimeters from each side of the abdomen. You can see the picture of the ports which are introduced, and this is from outside. Inside view, as we said, the doom triangle, which is a dangerous triangle formed by the vas deferens, the testicular artery, and peritoneal fold on the lateral side, which contains the external iliac vessels, and it is dangerous if you dissect in that area. The pain triangle, bounded by the iliopubic tract, the testicular vessels, and peritoneal folds. And also this pain triangle is dangerous to dissect in it, and it will cause some bleeding. This is a picture of the two triangles viewed from inside. The robotic assisted hernia repair, it is the same. You introduce the ports. Somebody will introduce the ports after the anesthesia, and the report will be in the hands of other person, and he is going to direct the operation even from anywhere in the world. We will go to the classification of inguinal hernia. There are certain classification of inguinal hernia, and this is good for the research, and it is good for mind storming. And for example, type 1 indirect hernia with normal ring, and this is usually the one we said is small, and it is in children and doesn't need a lot of work. It is only to return the sac back and just close the other layers. Type 2, which is indirect hernia with wide internal ring. The internal ring is very wide, and it might need some repair. Type 3, direct hernia with posterior wall defect. And this is also type 3, we can call it type 3A, direct hernia with posterior wall defect. Type 3B, indirect hernia with large internal ring and with a posterior wall defect. This is type 3B. Type 3C is the femoral hernia. Although femoral hernia is quite different from the inguinal hernia, like they are in the same area, but the femoral hernia is coming through the femoral canal down to the inguinal ligament, and the direct and the indirect hernias are coming from the posterior wall of the canal, inguinal canal, and the internal ring, and they are medial to they are above the inguinal ligament. More classification. 4A, it is direct. As we said, 4 is type 3C is femoral hernia. Type 4 is recurrent hernia. Any recurrent hernia, for example, if it is direct, it is 4A. 4B is indirect. 4C is femoral. Or any combination of these is called 4D. This is the simplest classification of hernias, and it is called the NIHAS hernia classification. What are the complications of hernias? Like any other operation, anesthesia and surgical complications are there. Bassini repair, for example, complication, it is under tension, recurrence rate is high, and like any other surgery, bleeding can occur, recurrence can occur, and even intestinal obstruction due to adhesions in intra-abdominal. Mesh repair complication, because it is a foreign body, it will add more infection, it will add more, it can slip, and recurrence also can occur in this category. Expect to have some questions on hernias, and if there are any other questions, we are ready to answer. And these are the touch on the hernia, and we left the clinical part to the clinical rounds. You have to be able, that is an important area of hernia. You have to be able to take the history, the cardinal symptoms of hernia. It's a pulse, number one, maybe pain, maybe it is recurrent, it will come and go, it is the bulge can come and go. Some of the complications of a hernia, which is attached to the hernia itself. For example, the hernia can get obstructed and or strangulated, and it can cause intestinal obstruction. And some of the hernias are reducible, and you have to differentiate about the content of the hernia and what are the content of the hernia due to the reduction. For example, you can differentiate between the omentum and an enterocele or bowel in the content. The bowel, for example, if you want to reduce it, is difficult to reduce the first part, and if the first part is reduced, the third part, the other part will go very quickly inside the abdomen. But the omentum or other structures, you can reduce it easily, but the last part of it, because of the adhesions, it will not go back. The omentum will be somehow, if you percuss, it will be dull in percussion, and the bowel will be resonant. You can hear some gurgling sensation in the bowel when the content is bowel, and in the omentum there is no gurgling sensation. It is soft and doughy. But there are certain things which also you can differentiate between two types of inguinal hernia. You can differentiate between direct and indirect, and that the inferior epigastric artery will be the demarcation. The direct one is lateral to the inferior epigastric, and the indirect is medial to the internal epigastric artery. And you can close the internal ring with one hand, with one finger, close the external ring with another finger, and close the femoral ring with the third finger, and this is what we call the 3-finger test. And who asks the patient to cough. Whatever is touched, you will notice that this is direct, indirect, or femoral hernia. There are certain clinical tests which can be done during the clinical rounds, and how to examine the hernia, whatever type of hernia, how to examine it, how to reduce it. And the best person to reduce the hernia is the patient himself. Ask the patient to lie down, the hernia will go back. If it did not go back, ask the patient to return it back into the abdomen, and he can reduce it easily. If he cannot reduce it, you can try to reduce it. The doctor can try to reduce it, and if it is not reduced, or if it is painful, you have to be careful that this might be an strangulated one or irreducible one. But it can be irreducible, obstructed, strangulated, or even gangrenous. But you have to be careful about these hernias when they are irreducible. You might notice there are certain things which can be dangerous to do. The reduction of gangrenous hernia is a serious one, and it needs an emergency operation. Next time we are going to talk about certain questions. We are going to answer certain questions on hernias, inguinal hernia, diaphragmatic hernia, umbilical hernia, epigastric hernia, Spegelian hernia on the lateral side, and we are going to answer questions about the incisional hernias, which are difficult to treat, and always they need a mesh, because incisional hernias usually occur after infection or after an operation which is got infected, and the muscle are getting weak and fibrous, and usually it will be a big one. So repair is a difficult thing, and it needs a mesh that will cover all the areas which are weak. Thank you very much for listening to the lecture, and we are going to come back for certain questions. If you start the clinical, anytime you work on hernias, you can ask some questions to the doctor, and he will help you to answer certain clinical questions on hernias. Thank you very much.